I think we're only operating at 50 to 75% of power in primary care. We're an underpowered specialty, in part from funding, but also in part from the design. We might not be able to change the funding immediately, but I think we can change the design to capture more of the power that we have to deliver. So there's decades of evidence that when we have more continuity with our patients, quality is better, costs are lower, fewer hospitalizations, fewer ER visits, lower mortality, and even down to medication adherence. Patients are more adherent to their medications when they have a continuity relationship with their physician or other healthcare provider. So I brought out a couple studies to show some of the value of continuity. This is the most recent one that I was able to find, and it looked at 4.5 million patients. They happened to be in Norway. And it looked at the value of continuity. And my guess is that we would see the same thing in the US. So the blue lines are patients who'd had continuity for a year or less with their primary care, their GP. Oops, we're not ready to move forward. And then all the way to the green line, which is those who've had continuity for 15 years or more. Now, I read that study again this morning. They did control for age and for the chronic conditions, the complexity index. And even after all that controlling, as the continuity improved, costs reduced, hospitalizations went down, ER visits went down, and mortality went down. And in my mind, there's very little else that we can do that results in that big of a change. So by prioritizing continuity, we can achieve some of those benefits. This is another study that I wanted to share with you because at least I know some of your family docs also around in the hospital. Is that still happening here and care for your patients in the hospital? So this study came out in 2017 and looked at 500,000 admissions. And if you were cared for by your personal physician during that hospitalization, you were more likely to be discharged home than to a different care facility. You had a lower 7-day readmission rate and you had a lower 30-day mortality rate. Now, that didn't hold true if you were cared for by a hospitalist or if you were cared for by another primary care physician who was not your personal physician. And then the third study I wanted to share around the benefits of continuity is one that we did with a healthcare economist. And what we found was that when primary care physician turnover happens, healthcare expenditures go up. So instead of getting care at a lower cost venue like the office setting, patients were going to the emergency room or were being hospitalized, or they were seeing another physician who didn't know them as well. And so more tests and more imaging studies were ordered. And if we could look at that, we found that there's about $1 billion in excess healthcare expenditures that payers, including patients, so insurers and patients, were exposed to each year because of turnover when the patients lost their primary care physicians. About a quarter of that we could relate to turnover due to burnout. So we know that burnout is expensive, but the bigger point I want to leave you with is that discontinuity is also expensive. So again, relationships are a superpower. We talked about continuity with patients, and I've given you some data from various studies showing the value of that. There's also a wealth of data showing that continuity within the team, the same clinicians working together, the same MAs and physicians, the same nurses and physicians working together day after day is associated with lower costs and higher quality, greater access to the community for care, and lower rates of burnout. So we can go on. And so I want to talk about the high cost of broken relationships. And I'd like to illustrate that with an example that I think will resonate with most clinicians. If you're seeing a patient whom you've never seen before, it might be one of your partner's patients, and they're in for a new condition, it might take 40 minutes, let's just say, to take care of this patient and to do a somewhat temporizing set of measures for this patient. You might do a few things to just put out the fire, and then have the patient come back in a week to see their regular physician. And what I've observed is I've been visiting clinics where I'm following a doctor who is somewhat less organized and efficient than one could be. And my husband was following another doctor who was seeing the patients that doctor couldn't see. So another doctor was seeing this doctor's patients. Well, that takes a long time. It takes, so we'll say 40 minutes to see someone that you're unfamiliar with. And if that patient was able to see their own primary care doctor, it might take only 20 minutes to see that patient. And so rather than the patient's original doctor just spending all their time entering orders and doing other kinds of administrative tasks, if we can remove those tasks from that physician, then they can be available to see their own patients when they call in and take 20 minutes rather than 40 minutes to care for that. That reduces the work for the whole system if we can prioritize relationships.
Hi, ma'am.
So I want to just re-emphasize this idea that discontinuity doubles the work for everyone. It doubles the work for the rooming staff who have 2 visits rather than 1, for the billing staff, for all of the additional support staff, and it doubles the work for the clinical staff as well. So if we can prioritize relationships, we reduce that waste that happens when we're seeing someone we don't know well and create more capacity. So here you're going to have to be with me because we'll go quickly. So this virtuous cycle that I believe we can all aspire to and move toward starts with relationships and continuity and building the systems that make it more likely that when you call in, you'll see your doctor. And then we combine that with operational efficiencies, and we'll talk about some of those, what we call the practice fundamentals. And then we decrease the total amount of work that the system needs to do to care for a set number of patients. And then that increases our capacity and increases our access. You're doing a great job. So that's our superpower. And again, the question is, how can health systems and how can individual leaders and how can individual clinicians prioritize relationships? And so I wanted to give you a few examples to stimulate your thinking, not to be prescriptive, but more to say, these are some of the examples that I've seen that resonate with my own experience or that we have some data around. And my offer to you is take those home and think about them. You may be doing most of them, but maybe there's 1 or 2 that you're saying we could make some variation on that here. And so we'll be looking at this from 7 different dimensions of system level approaches that can help us prioritize relationships and hopefully reduce the total amount of work that needs to be done, increase the satisfaction of the workers. So the first is continuity. We've been talking some about that, but I'd like to share another study around continuity. And this is one that comes out of Chicago. And the heading, I think, of the study is kind of an interesting one: Reinventing the Medical Assistant Staffing Model at No Cost in a Large Medical Group. And what they did was they did not add any additional staff. They kept the same number of medical assistants, but they prioritized stable pairings so that the same physician and medical assistant would work together the majority of the time. And what they found was they had greater capacity. They had 11% increase in their RVU generation. They didn't add any costs, but they prioritized how they used that resource. They also found that they had quality metrics that were better. The physician satisfaction was greater, and they felt that the MAs had more investment in the success of the practice. So then the pandemic hit, and I checked back with Dr. Ilbalawi, who was the principal investigator of that study, a family physician at that organization. And I said, well, how are things going now? And he said, the clinics in which we had the stable pairing are the only clinics in which we have full staffing. So that was the only clinic where they were able to hold on to their medical assistants. And to me, that makes perfect sense, because instead of just being a worker, those medical assistants were connected and had meaning in their work, meaning in their relationship with their physician. And I asked him if he'd send me some pictures of those pairings, and I think you can catch some of that sense of commitment to each other and some of the joy in working together that those pairings demonstrate. So the second dimension is communication. And here I'm going to hopefully do a reasonable job of summarizing one of Marlon Munt's studies. And I've always liked this study because he was able to demonstrate. I need to move this out of my way here, see if I can do that. And I believe you surveyed about 155 clinicians at several different clinics, and you found that as the density of EHR communication increased, clinical outcomes decreased. And conversely, as the density of face-to-face communication increased, then outcomes improved. So there were better clinical outcomes, fewer hospitalizations, fewer urgent care visits, fewer ER visits, and strikingly, less cost. Almost $600 less cost per year. And Marlon, you'll have to remind me, was that less cost per patient? That's what I'm remembering. Yes, thank you. All right, so let's move on. So what else can we do to help with that communication and that continuity? Just here's another example from our own practice. Whenever we had a new patient who came to our practice, and if one of our rooming nurses had roomed the patient, I would walk them up to my primary nurse, who was the quarterback for the practice, who did most of the phone care, but also roomed many of the patients. And she would get up and they would shake hands, and I'd say, "This is my primary nurse, Deb. If you have any questions between now and our next appointment, I want you to call Deb." Speaking with Deb is like speaking with me because we work shoulder to shoulder every day. And I wanted there to be no barriers between the patient reaching out to us I didn't want them to have any confusion as to how to reach out to us. We also gave new patients a welcome to our practice brochure. And it had a picture of all of the nurses, the 2 doctors and the 5 nurses who were, well, there was only 4 at that time, who were in our particular pod or our hallway. And then what their names were, what their roles were, what they could expect from us, and what we asked of them, what we asked of the patient. So then the next dimension is the physical space, because how the space is designed, just like how your kitchen is designed, makes a big difference in terms of how efficient you can do your work and how safely you can do your work. This is a flow station from North Shore Physician Group, and they found that when the physician and the support staff were seated side by side, they were able to save 30 minutes of physician time per day. And they saved that by eliminating the need for some of that electronic communication that goes round and round in the office and doesn't really communicate the nuance, as Marlon and I were talking about earlier, that you can communicate in a face-to-face communication. And I've seen that co-location 10 years ago or so when I visited the Yahara clinic here. You may have it at some of your other clinics as well. Next, I want to turn to scheduling. And I would say scheduling is a place where there's probably where we have the most blind spots, where the blinders are, and where we have the most opportunity to improve the flow and to get rid of some of the waste. So let's talk about how that might happen. First, I'll share a quote from, I was giving a talk to a children's hospital and clinic group out east, and someone put into the chat, "Scheduling patients with the next available physician creates a cycle of the primary care physician being booked up with other people's patients when their own patient calls in for an appointment." That phenomena where one doctor is in the office, but they're so busy doing all the administrative tasks that another doctor or other clinician is seeing their patient. And so I want to introduce the concept of wave scheduling. Do you do any wave scheduling that you're aware of here? So it comes out of queuing theory. We were doing it in our practice, and I had no idea what queuing theory was. But when I looked into it, it comes out of the notion of queuing theory. And so here we're going to have to be in sync again. Because most organizations, I believe, and we did initially in our own practices, schedule as if there's a series of rigid time blocks and that each patient gets a rigid time block. And I think that that's actually a recipe for lack of success. That's going to be a very frustrating experience. If you see the schedule, it's just a series of rigid time blocks. You've got one person in each time block. And so here's how that looks over a morning. You've got each patient has a different time. But then what if the first patient doesn't show? Then that wastes an entire 30 minutes. Okay, what if the next patient, who also had 30 minutes scheduled, really only needed 15 minutes? It was a much shorter visit. Sometimes people who have multiple chronic illnesses actually don't take that long if you know them well. So this patient, all was good, but then you wasted another 15 minutes in this rigid way. And then the 10 o'clock patient, well, they actually took a lot longer. It sounded like it was a straightforward problem, and that's what they were scheduled for. But straightforward problems, I'm fatigued, that's not actually a straightforward problem, even though it's a single urgent visit kind of problem. And so then that puts everything behind, and you get this cascade of running late that follows. So let's move on. So the idea of wave scheduling and what we did in our own practice is we had 2 patients at the top of the hour and then 1 patient at the half an hour, or at least that would be one version of this. And so what that does is it gives you a little micro buffer within every hour. And so you have the ability to relocate some of that time within the patients who are within that hour, depending on their need. And so let's move forward again. Now and then I'll show you how it might look if you've got 4 patients an hour. You might have one patient who's got a longer appointment and one that's shorter at the top of the hour. And then you might have 2 more at the quarter hour and at the half hour. And then you still have that micro buffer. This is more what we were able to do. We had 2.5 nurses per physician, and we had a stable practice. But again, that way, when you schedule on a wave, it allows you to more efficiently adjust to the knowable, the predictable unpredictability of patients' needs. So let's keep going. And so another key element in terms of scheduling that I think is underutilized is to routinely reappoint every patient at the end of each visit. Instead of leaving the room and the patient's got their deer in the headlights look like, okay, what next? That you intentionally set the patient up for their next appointment and any lab or test that they might require ahead of time. You already know it because you've just been deep in their situation. So there's no need to repeat that a week before an upcoming appointment. Do it now while you know them, while you know what they need. And that simple act reduces a lot of staff time and a lot of missed opportunity for care. And so one of the key things about that is you have to be able to schedule 12 to 15 months in advance, which means you will inherently reschedule a small percentage of those patients because of your needs or their needs, but you're not rescheduling 100%, which is what the alternative results in. So then let's move on to team-based care. And we'll go to the next slide. And there are many examples of advanced team-based models of care where there's a higher level of staffing and a higher level of skill among the medical assistants or the nurses who are part of the team. The example that I chose to share with you this noon is from the University of Iowa because it's the most recent one that I encountered. And at the University of Iowa, in their family medicine department, they have gone to 2 MAs, 1/2 RN per MD. So, and this is very, very similar to the practice that my husband and I had and the other internists and family physicians had in our practice. And so the support staff did the pre-visit work. They did some pre-charting and do expanded rooming. They would close all the care gaps, give all the immunizations, make sure that mammograms are scheduled if they hadn't been done ahead of time. And then at the visit, they would help with real-time order entry, real-time visit note documentation, and more recently at Iowa, they also are able to use the AI documentation as an enhancement to this model. And then in the post-visit, the medical assistant stays behind and makes sure that the patient has all the self-management support that they need, that all the next steps have been arranged. So what did they learn? Well, they were able to decrease time in notes for their physician, both whether they did it in the earlier version without AI or the current version. And I know that here at UW, you've had AI documentation support, and that's reduced time in notes. They were able to increase teamwork for orders, one of Epic's measures that you can directly pull out of Signal, threefold. They increased the number of visits per session by 33%. They increased the net revenue by 46%. That's net revenue after the cost of that additional staff was taken into account. And so what they found was they were able to bring in $600 more per half-day session of revenue. Well, you can look at that from the chief financial officer's point of view, also from the chief medical officer's point of view, because that reflects increased access. So here's their data. So they went from making about $1,300 per session to $2,000. When they took out the cost of their staff, it was a $600 net benefit. All right, so technology. We're going to talk a little bit about inbox. And I think most of you are aware that the volume of inbox messages coming into physicians and APPs really bumped up at the beginning of the pandemic, and it never dropped. And if you have a high level of inbox volume, you have six-fold higher odds of burnout if you're in the top quartile compared to the lower quartile. And some estimates say that each patient medical advice request is associated with a little over 2 minutes of additional work per. So with a colleague, we wrote an article for the New England Journal Catalyst with some examples of how she at Atrius in New England had been able to reduce the volume of inbox totally by about 25% by reducing prescription renewal requests, CC charts, other ADT notifications. So there's a lot of detail in that New England Journal Catalyst article. We also created an AMA Steps Forward toolkit on inbox reduction. That's free and accessible to anyone. And we have a checklist, an inbox reduction checklist, just a 2-pager with some things that you can look at and say, are we doing these things that can help reduce the inbox? My main guidance on reducing the inbox is to go upstream, DC the CC. Don't CC, don't have your single system specialist CC notes just because they can, but only when there's a customized note of what action they're expecting to happen based on that CC. Don't make you read through a needle in a haystack, do the needle in the haystack to try to figure that out. You order it, you own it. Instead of sending test results to multiple physicians with the idea that that's actually a safety issue, if you order it, you own it. Don't send it to multiple physicians because that actually leads to ambiguity about who's responsible. 90+4. In my view, if we got a call for a prescription renewal, that indicated a breakdown in our system, a call or an inbox message or a pharmacy message. And I would say you don't need to ever ask patients if they need their prescriptions renewed. Develop a system where you don't depend on that. I mean, I'm a pretty sophisticated patient. I have no idea if I have some prescriptions that are randomly needing to be done. At the annual appointment, at one appointment every year, just renew them all, whether they need it or not. And you will save yourself 50% of the calls coming into the clinic. Do pre-visit lab. Quickly here on team order entry, there's a wealth of studies. Oops, I think we need to move forward. There you go, one more. That team order entry, rather than mandating or expecting that the physician or APP is the one who's going to enter every order in your organization. The team order entry saves a lot of time, 4 to 8 minutes per patient from MGB, Mass General Brigham. University of Alabama found that they had 20% higher RVU generation with team order entry. Also increases the focus on the patient and reduces the odds of physician turnover. So I want to talk a little bit about AI documentation. I know you have that in your in many of your departments. This is I did a review of all the AI documentation studies that were done for another exercise. And the strongest one, so this is the most positive results that I found, but it was also the largest, comes out of Mass General Brigham, where they had 800 physicians and APPs of multiple specialties. And after 3 months, they found that work outside of work, or pajama time that Brian Art had talked about, reduced from 90 minutes a day to 30 minutes a day. Because that documentation is basically done at the end of the day for most physicians. They also found that there was some other benefits, including a 20% reduction in burnout. So then the last dimension, it's my favorite dimension, and that is getting rid of sludge. And so one of the things we did when I was at the AMA is we put together a list of things that we thought could be de-implemented. So I was intrigued by last night learning that there's a researcher whose focus is de-implementation. So we put together a de-implementation checklist. We sent it around to 10 or 12 CMOs around the country to get their feedback, and have then this list of suggestions that you might sit down with your administrator and say, are there some opportunities for us in our department, in our unit, to de-implement things that may have at one point seemed to make sense, but may no longer be of benefit? So we'll end with a promise that I heard at an IHI meeting probably close to 20 years ago now. A group in Michigan had adopted as their mission statement this promise to patients: we will know who you are and we will be ready for you. I want you to think about that. We will know who you are and we will be ready for you. And think about, what are the workflows, what are the staffing models, what are the scheduling models that will help each of you deliver on that promise. We will know who you are and we will be ready for you. And I think a lot of that can come through the practice fundamentals, through how do we reappoint patients? Do we schedule on a wave? Do we have the ability to see our own patients when they call in? Do we have that buffer so that when someone calls in, we had an open door policy in our practice. We said, if you call us that day, we will see you that day or the next day. That is our promise to you. And we wanted to be ready for patients. And that's where empowering our nursing staff and doing a lot of pre-visit planning allowed us to do that. And we got some space for that by the teamwork, by the shared work with our staff, and by getting rid of unnecessary work like prescription renewals, which you can get rid of most of them by how you handle that. So before we come to a conclusion, and hopefully you'll have some comments, wisdom to share from your own practices or some questions, I want to leave you with that question. How would care look different in your sphere of influence as an administrator, as clinicians, as researchers, as leaders, if every decision was held up to, well, how does this affect relationships? How does it affect stability within the team? How does this affect continuity? And my belief is that if we make decisions that include that dimension, that we will make better decisions for our patients, for our staff, and for our physicians and APPs. So with that, I want to thank you so much for your attention.